Hello, my name is Charles Pollack. I'm professor of emergency medicine at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia. Welcome to this panel discussion titled Update on Antidotes for Oral Anticoagulants. I'm pleased to welcome my colleagues, Dr. Gerald Levy, who's professor of anesthesiology and associate professor of surgery at Duke University in Durham, North Carolina, and Dr. John Eichelboom, who's associate professor of medicine at McMaster University in Hamilton, Ontario. Gentlemen, thank you for joining me.
Thank you.
Today we're going to discuss the role of potentially seeking to reverse the action of the novel oral anticoagulants. As you know, there's been increased use of these agents around the world as a replacement, potentially, at least in some indications, for vitamin K antagonist therapy. And there's the perception that vitamin K antagonist therapy is reversible. That is, it can be taken away when needed because of the patient's bleeding or the need for emergent surgery or some other intervention that could cause bleeding. Whereas the perception about the so-called NOACs, again, novel oral anticoagulants, is that they might not be as reversible and therefore might not be as safe. So our goal today is to talk about how these drugs are used and when we might want to consider treating patients who are bleeding on one of these agents with a reversal agent versus more generic support or transfusion therapy without an attempt to reverse. So let's start off by talking about the supportive care that patients who are bleeding when being treated with an oral anticoagulant need. Jerry?
Well, I think that's an important question. A patient who comes in, presents in the emergency room with some GI bleeding, who's hemodynamically stable, usually stop the anticoagulant and sort of observe the patient. The real question is when the patient comes in hemodynamically compromised. And in that situation, I think there's a lot of thought about specifically treating the coagulopathy, which is critical, but it's really a multimodal approach of first resuscitating the patient, restoring intravascular volume, restoring the red cell mass, doing the simple things, and then thinking about sending off coag tests and treating other aspects of that patient. But I think there are important perspectives in the patient who really presents hypotensive, in shock, or something of that nature. GI bleeding is not that common, but more in a patient after perhaps a major procedure, post-traumatic, or another scenario. John, what do you think?
Well, I think what you've just told us about the management of serious bleeding in the emergency room is very important. We actually have a lot of experience managing serious bleeding, and the management of bleeding in a patient on a new oral anticoagulant is not that different from any other patient who has a really serious bleed. What I'm getting at, it's a lot about perspective here. Sure, we'd like to reverse a drug, but the principles of controlling the bleeding, stopping the drug, and resuscitating the patient dominate our initial management.
So you're both speaking about the basics. One of the basic considerations here pharmacologically is that all of the NOACs share a much shorter half-life than warfarin. So to the extent that these patients need to be supported while there's still an active anticoagulant on board, that time period is shorter. We do consider sometimes in these patients, though, giving hemodynamic or hemostatic therapy. How are the NOACs different from a warfarin-treated patient in that regard?
Well, certainly in terms of warfarin, we have a lot of information about potential reversal agents, and we can give vitamin K to counteract the effect of warfarin by enabling the patient to begin synthesizing functional clotting factors. We can replace clotting factors that have been inhibited by warfarin, so we can use fresh frozen plasma. And we can use concentrates of clotting factors, so prothrombin complex concentrates. And all of these three agents certainly have efficacy at reversing warfarin. The question is how effective, how efficient are they? And perhaps even more specifically, in the patient with life-threatening bleeding, is the use of these agents leading to better outcomes?
Well, the issue of life-threatening bleeding brings up something that Jerry specializes in as a critical care provider, and that is that these patients need their blood pressure supported, they need their volume repleted. It's not just a matter of treating the drug that caused their coagulopathy. They have to be resuscitated as well.
Absolutely, and I think the critical thing here is that, do the simple, basic resuscitative measures, as we mentioned, figure out what the volume is, figure out sending off labs, doing hemodynamic support, volume administration, and figuring out what needs to be treated, especially if the patient's anemic. I think an important point here to consider, though, is that in critically ill patients, all anticoagulants can produce bleeding. We see it with heparin. We see it particularly with low molecular weight heparin, especially with renal dysfunction, because it has a greatly prolonged half-life. And therapeutic options there are minimal. John talked about fresh frozen plasma, and I think one misnomer and perspective that needs to be considered is that even with fresh frozen plasma, if you give, say, 4 units, the lowest INR you can ever get is about 1.5. And how many times have we seen clinicians give INRs 1.5 and they give fresh frozen plasma? Just not helpful, where prothrombin complex concentrates are useful in that situation. So I think there are a lot of interesting, important perspectives. The other interesting thing is that one of the most common causes of transfusion-associated acute lung injury is the use of FFP to reverse warfarin. About half the cases reported several years back to the FDA were the use of FFP to treat warfarin and to reverse anticoagulation. So I think FFP is critical as part of a multimodal approach, but if we really seriously want to reverse warfarin, we have to think about additional therapies. John really mentioned it's multimodal too, but again, if you have a patient who requires a major procedural intervention, acute intracranial hemorrhage, or other scenario where you need acute reversal, you really have to think about a prothrombin complex concentrate.
Another basic of resuscitation with fresh frozen plasma is that, of course, it's quite a bit of volume. You just spoke of giving someone 4 units of fresh frozen plasma. A lot of patients who are chronically anticoagulated, for example, for stroke prevention and non-valvular atrial fibrillation, are older patients who can't handle that kind of volume.
Absolutely. And, you know, there's, in addition to TRALI, there's this thing called transfusion-associated circulatory overload, or TACO. And 4 units of FFP in a critically ill patient with atrial fib who comes in bleeding, who's normal volemic, that's enough to push them over into pulmonary edema. So the warfarin story is a complex story that we still sort of work through in 2013. And what's interesting in the United States, as you know, up until just May of this year, there was no 4-component prothrombin complex concentrate available to treat that.
Again, differentiating before we move forward with discussion specifically reversal, the idea of resuscitation versus reversal. These patients are bleeding. They're hemorrhaging. Unless it's an intracranial hemorrhage, they're hemorrhaging potentially externally, as you mentioned with GI bleeding. Sometimes these patients need red cell transfusions, need to replace what they're losing. And I think it needs to be recognized that those patients don't necessarily need fresh frozen plasma. At the same time, they need packed cells.
Exactly. I think it's another important perspective, especially elderly patient who may have impaired erythropoiesis, who has perhaps cardiovascular disease, ischemic cardiovascular disease. I think when they're profoundly anemic, you need to think about red cells and certainly type and cross them for red cells. I think that's an important part.
So, John, in introducing this topic, we spoke about the fact that there are some physicians maybe not as familiar with the novel oral anticoagulants whose knee-jerk reaction is you can't reverse them, and so therefore they can't be safe. Can you help us put reversal into the context of the clinical care of these patients? Because many of them could be resuscitated without ever needing reversal.
Yeah, I think that's a key point. The majority of patients who present with bleeding are not going to require a reversal agent. If we think back at our experience over the past decade with drugs such as aspirin and clopidogrel, people coming into the emergency room, we see bleeding. Most of these people, supportive care is sufficient, and I would hazard a guess that 90% of bleeds patients on a new oral anticoagulant, we're not thinking about reversing them. We're going to treat them supportively. The offset of the anticoagulant effect of these drugs is rapid, and supportive care is all that's going to be required.
It's a nice idea, though, isn't it? I mean, the patient is bleeding. You know they're on an anticoagulant. It would be nice to just take the anticoagulant out of the circulation. And as we'll discuss, there may be ways in the not-so-distant future to do that. But in the meantime, I think it's important that we look at how these patients are managed now, in the absence of an antidote for the novel orals, and with the sort of varying practice around the world in terms of managing patients who are bleeding on a vitamin K antagonist. I know, John, you were one of the authors on a recent study that looked at the dabigatran versus warfarin experience, and I think 5 randomized trials of dabigatran. You want to take us through that?
Certainly. The Majid paper, which is published in Circulation, set out to address this issue of outcomes or the management of bleeding on dabigatran compared with warfarin and outcomes after bleeding. And it was prompted by all of this hype, this concern we can't reverse these drugs, surely that must lead to inferior outcomes. What Majid and colleagues did, they combined the data sets of the 5 large trials comparing dabigatran with warfarin, more than 27,000 patients, more than 1,000 major bleeds, so incredibly robust data in terms of numbers and statistical power. And then in the paper, they reported the management of bleeding and outcomes after bleeding. And the single most striking feature of this report was if we simply look at people who survived to 30 days after a major bleed on dabigatran, the drug without the specific antidote, and warfarin, the drug that we're also familiar with that has the antidote, we see that case fatality is 1/3 lower on dabigatran. Now the p-value is nominally significant, 0.052 I think the number was. So strictly speaking, one might say, well, it didn't quite meet the conventional criteria. But the key point here is there is certainly no evidence that if you're on the drug without the antidote, that you have worse outcomes. To me, tremendously reassuring data for the jobbing clinician.
Now, these were major bleeds, so obviously some of them got ICU care. I understand there was a difference in the length of stay in the ICU as well between dabigatran and warfarin.
Correct. So there is more information in this paper. So this included critical care patients. The time in the ICU was actually reduced when you're on a new oral compared with warfarin. There was a little more transfusion in the dabigatran group. Now, we haven't drilled quite down to that, but I think that's almost certainly due to a GI bleeding issue. So we know there's a little bit more GI bleeding with the higher dose of dabigatran compared with warfarin. But again, the key issue here is when we consider what the ultimate outcome is for the patient, we'd be better off having a major bleed on dabigatran than on warfarin. One additional point to consider, this analysis includes intracranial bleeding. Intracranial bleeding, once you get a bleed into your head, we know pretty much nothing can be done to improve outcomes in terms of hemostatic support. We haven't proven that anything improves outcome. If we took those people out, the signal in favor of dabigatran is even stronger.
And it's important to remember that all of the novel orals actually have a lower rate of intracranial hemorrhage than warfarin patients who are in the respective trials against those novel agents. You spoke about the ultimate outcome. The ultimate outcome, of course, is mortality after a major bleed. And in the Majid paper, mortality was significantly lower in patients treated with dabigatran versus those treated with warfarin. And of course, the management strategies applied to those two groups of patients differed. And that's one of the things we're focusing on today is how these patients should optimally be managed, again, with the antidote approach of vitamin K versus now as you mentioned, Jerry, the increasingly available around the world use of prothrombin complex concentrates, and then potentially the use of those drugs in the NOACs as well. But as far as the rest of the Majid data go, one of the things that helps us determine perhaps is how frequently patients need reversal. John's already said that it's not that common. You can manage these patients who are coagulopathic because they're on an oral anticoagulant without actually taking the drug out of circulation. One of the concerns about that, of course, is you may make the patient prothrombotic, and they were being anticoagulated for some reason to begin with. But Jerry, with your experience in critical care, what do you think is the real need for reversal, and when do you know it when you see it?
Well, first thing, I think an important point that both of you brought up is the pharmacokinetics of the NOACs is that they are reversible inhibitors versus warfarin, which makes defective synthetic 2,7, 9, and 10 that takes days and days to sort of make the appropriate one. And the fallacy that vitamin K is basically an antidote for warfarin is vitamin K plus 3 to 5 days on the calendar is what's required because it takes a long time to return synthetic function. Now, most of the prothrombin complex protocols use vitamin K as well as a prothrombin complex concentrate together, but vitamin K is not it's not an antidote, but it's a treatment strategy, in my humble opinion.
As an emergency physician, I think of an antidote as being naloxone in an opioid overdose.
Absolutely.
Or pyridoxine in someone who's seizing because they overdosed on isoniazid. That's something where the drug takes the problem away, and vitamin K does do that. Vitamin K allows the body that may or may not be a healthy body to start resynthesizing these factors that are required for hemostasis, and that's not an immediate impact.
Absolutely. And just as sort of a quick aside, my patients, 50 to 60% develop atrial fibrillation after cardiac, vascular, major procedures. And when you start warfarin, 2 to 3 days later, maybe an extra couple days in the unit, trying to adjust their INR, trying to get them anticoagulated. The amazing thing about the new anticoagulants, you give a dose, in 2 to 4 hours, you're therapeutic. 2 to 4 hours, you don't have to bridge with heparin. You don't have to worry about heparin-induced thrombocytopenia. It's a whole new treatment paradigm. Of course, again, as we mentioned earlier, all anticoagulants have the risk of bleeding. I mean, that's part of the therapeutic efficacy.
Right.
But the point is that I think the uniqueness of the reversibility, and with reasonable normal renal function, the drugs are cleared relatively quickly. But to get back to your original question in the intensive care unit, when do you reverse and when do you actually have to treat these patients? I think one of the critical concerns about when you have a patient on a new oral anticoagulant who comes in, I think if they're requiring major procedural interventions, i.e. a major surgical procedure where they're anticoagulated, that's a situation where I think you really need to assess, one, their anticoagulation, two, wait a couple days if you can. If not, then I think those are the patients that you really need to think about potential for some sort of therapeutic strategy to attenuate the anticoagulation that's on board. The other question always comes up is the patient post-traumatic who may come in for a procedure. But part of the problem is patients after major injury bleed for a multitude of reasons. Mm-hmm. And it may or may not be related to the anticoagulant. People assume that, but there are a lot of reasons why patients bleed.
So John, are there patients who, as soon as they present, are reversal candidates? Is an intracranial bleed on an oral anticoagulant, for example, is that someone who needs to be reversed even as you're doing the standard resuscitation techniques?
Well, it seems like a very simple question with a simple answer. Yes, you should reverse these people. When we think about it more critically, most intracranial bleeds, when they arrive in the ER, they're at least an hour. They may be 2, 3, 4, 5, 6 hours plus since the onset of their bleed. It's very unlikely, I believe, it's very unlikely that immediate reversal of the anticoagulant effect in such patients will impact their outcome. Having said that, we are doing whatever we can to avoid morbidity and mortality in such patients, and therefore I think it's very reasonable to give them whatever we have.
So what about patients who have a major bleed, life-threatening bleed, but not intracranial? Are there circumstances you can envision where you would immediately go to a reversal agent, or is it always resuscitate first and then assess?
Well, I think if we had a reversal agent on the shelf and if someone came in with a life-threatening gastrointestinal bleed, part of the therapeutic strategy would put the lines in, draw the bloods for the laboratory assessment, begin resuscitation, and as soon as one has confirmed that the patient is taking an anticoagulant, one that is reversible, one would infuse the reversal agent. I think that would be very reasonable. In a patient we know their life is threatened, in a patient where we know that reversal of the bleeding is likely to positively impact their prognosis.
Now you bring up an interesting point there. You send the lab test. Of course, one of the problems with the NOACs is that you can't readily assess to a quantitative degree the way you can with an INR on a patient taking a vitamin K antagonist how anticoagulated they are. You can tell if they're anticoagulated, but not necessarily how anticoagulated they are. And I think that, again, adds to the potential insecurity of physicians in using these agents.
Although, let me disagree with you if you don't mind, because I think with the 10A inhibitors, with rivaroxaban, apixaban, edoxaban, measuring its effect, it's a little trickier. You need a specific 10A calibrated assay. But with the Bigatran, you can use more standard assays, i.e. the partial thromboplastin time is a reasonable screening test. A better test is a thrombin time, which most hospitals have. And then the better test is even the diluted thrombin time, which comes in several different iterations. So using reasonable standard tests, like you would with any direct thrombin inhibitor, I think you can more readily assess. That's been, and I'd appreciate your experience, but that's been my clinical experience. You know, having an INR prolonged about 1.3, 1.4 is very common in a lot of sick, critically ill patients. It's hard to interpret that data with a 10A inhibitor, but I think it's easier to measure the dabigatran direct thrombin inhibitor effect than the 10A effect. Your thoughts?
Well, I agree completely, and we set out a couple of years ago with the Hemoclot test. We realize now that with our hospital APTT and with the thrombin clotting time, we can evaluate the level of anticoagulation in a qualitative sense very reasonably and very rapidly. I think also in relation to, say, rivaroxaban, although it's true we ideally need anti-10A assays, with a sensitive prothrombin time reagent, we can do pretty well. So I'm less pessimistic about being able to get a rapid evaluation certainly with dabigatran than you had suggested. It takes nothing away from the obligation of hospital laboratories to implement available testing for all three, for all of the new oral anticoagulants.
But wouldn't you agree, one of the things that we've always used, if the thrombin time is normal, it pretty much excludes an effect of dabigatran, and it's not as linear as perhaps thought versus the Hemoclot or diluted thrombin time, but I think it's a very sensitive screening tool. Your thoughts?
Absolutely agree.
Yeah, I agree with that, and it's used in the emergency department in that way. The problem is, of course, some smaller hospitals, thrombin time is not available around the clock, but it typically is available in the laboratory. So to the extent that we're going to use a reversal agent, we can measure INR. We get a good sense quantitatively of where a warfarin-treated patient is in terms of anticoagulation. What is the standard of care now with the new PCCs out there, with vitamin K, with fresh frozen plasma? What do you think should be the standard approach to the warfarin-treated patient with a life-threatening bleed who you've made the clinical decision does need to be reversed?
Well, with the warfarin-treated patient in 2013, I really think when they're bleeding, I really think you need to think about a prothrombin complex concentrate. And what's pretty impressive, if you look at factor levels versus INR, an INR of 2 to 3 is basically a factor level of about 20 to 40%. And the reason why we've gotten so good at that is because in a lot of the patients, we're transitioning over to oral warfarin after mechanical assist devices. We use chromogenic factor 10 assays. The point, however, is that to increase those factors to restore your coagulation function, the four-component prothrombin complex concentrate, to me, makes the best sense. Several of the points that you brought up about fresh frozen plasma, the INR issue of being able to normalize your INR, it's incredible because you solubilize in about 20 mils of solution. You give intravenously, and within minutes, you normalize your factors and correct your INR. In the critically ill bleeding patient or the patient undergoing major procedural intervention, in the patient who's not bleeding, that's a totally different scenario. But I think, as you point out, for the major hemorrhage and the patient who needs emergency surgery with a high risk of bleeding. Thoughts, comments?
You'd still give vitamin K, though.
Absolutely, as a concomitant therapy, and it's the
to
PCC.
Help down the line.
Very important point. And to shut off the effect of the circulating warfarin that has a very long half-life.
So until the PCCs came along, the concept of warfarin being emergency reversible really was a little fallacious.
Absolutely. And the problem is that, and clinicians still think it is with fresh frozen plasma. How many times in your institutions do you see people giving fresh frozen plasma for an INR of 1.4, 1.5? It's common.
When you do reverse, how big is the concern for a thrombotic event? Sort of the going too far, if you will.
Well, the quick answer is whenever we remove an effective anticoagulant in a patient who has an indication for anticoagulation, we expose the patient to a risk of thrombosis. And we ought not to be surprised about that. If they didn't have an indication for anticoagulation, then there may be no risk, but anybody who needs an anticoagulant is at thrombosis risk. The question really is, do we further accentuate that risk by the process of reversal? I think the best evidence suggests that we do induce a brief hypercoagulable state with heparin. We may do the same when we withdraw heparin. We may do the same when we withdraw warfarin. I think it's safe to assume that all of the agents will induce somewhat of an excess of events.
And obviously, as they are studied more and more in the NOAC-treated population, we're going to get a sense of how much of an issue that is there. Good pharmacovigilance will answer that question for us, but it's not going to happen overnight. So that brings us back to the NOACs. Now, you've just, I think we've all agreed that PCCs are standard of care now for patients who are bleeding as a result of a warfarin-induced coagulopathy. What about the NOACs? We have healthy human volunteer data, we have animal data, we have in vitro data. Do we really have enough data to use the PCCs in NOAC-treated bleeding patients right now?
Well, let me start with rivaroxaban and the data that's out there. The Ehrenberg study that Marcel Levy and the group from Holland did basically looked at rivaroxaban in a 4-component PCC. And they were able to, for the most part, normalize the INR and normalize trauma generation. A second study that I was involved with that we presented at the ISTH is a similar study. We looked at 4 versus 3-component prothrombin complex concentrate. And surprisingly, the 3-component prothrombin complex concentrate, which lacked factor 7, worked reasonably, but 4-component prothrombin complex concentrates seemingly worked the best for restoring INR and restoring trauma generation. The interesting thing of all of the studies is that we need better studies that actually look at it in the bleeding patient. These were studies in volunteers who are anticoagulated. But I think we need more studies in bleeding patient to better specifically state whether it's effective at reducing bleeding. The thing about it, though, is that you don't have to always normally 100% correct all the coagulation abnormalities to decrease bleeding. And there's a little bit of a disconnect between laboratory testing and bleeding. So I think that's another important point.
So bottom line, the data are very preliminary. They are promising, but we have no proof that the use of what I would call in this situation general hemostatic agents such as the non-activated or activated PCCs improve outcomes. In a life-threatening situation, I think it's very reasonable to use these agents, and that would be consistent with what most guidelines would suggest.
And when you've got a patient, I think we've done a pretty good job of describing the patient who needs reversal. This is a sick patient. And I think in that situation, if you've got a NOAC-treated patient, you should feel comfortable trying the PCCs because you may be at your last resort for that patient.
Correct.
That being said, there are in development a number of different antidotes that are specific to the NOACs, to dabigatran on the 2A side, and then there are also antidotes being developed for the anti-10A anticoagulants as well. John, what can you tell us about the Fab fragment that's been developed now to treat dabigatran bleeding?
Well, this brings us to your early point earlier on in the discussion that ultimately we do want these reversal agents. We have 2 great prospects, one for the 2A inhibitors, one for the 10A inhibitors. The 2A reversal agent is an antibody fragment which actually works extraordinarily well. We've seen some early data with the use of this fragment in patients or in volunteers who are treated with dabigatran, and this stuff seems to work like magic. Infuse a dose of the FAB fragment and instantly and completely we see reversal of the anticoagulant effect of dabigatran.
How long does it last? Do we know?
Well, we know it lasts certainly hours. We're going to need additional information on does it last 48 hours, 72 hours. One can envisage that this drug would soak up most of the dabigatran in the system. Is there still some release of dabigatran from the extravascular space? Are we mopping up all of this dabigatran? I think the best evidence we have that it is, but I don't know that we have the final answer to that.
The advantage of the FAB fragment is it reverses it without producing hypercoagulability like the other mechanism. One quick comment, though, is that in a life-threatening hemorrhage, clinicians do what they have to do in terms of management. But one therapy that I think should really be not thought of is the off-label use of recombinant 7A. Most of the data suggests it's not really effective, where I think if you're going to use off-label in a life-threatening emergency, as John said, that there is not enough data, I think, in clinical bleeds, but I think thinking about activated versus non-activated PCCs makes more sense in these patients than off-label use of 7A, because most of the data suggesting 7A being effective is not useful in these patients. Thoughts?
Yeah, I mean, my understanding is that the majority of use, at least in the U.S., of recombinant factor 7A is off-label. I think that if we have something a little more specific, and in this case with the multi-factor concentrates a little broader, it would make sense to try to bring those into play for these very sick patients. You spoke about the dabigatran Fab antibody as soaking up the dabigatran. Obviously, it creates an antigen-antibody bond there with the dabigatran. It pulls it out of the circulation that way. The anti-10A antidote that is being developed works in a different way.
Indeed. So this is a factor 10 decoy, so to speak. That's the nicest way of putting it. It's a factor 10 that doesn't have coagulant activity, and it'll compete with the factor 10 for the drug, and thereby binding to drugs that target 10. It can also very effectively remove anti-10A inhibitors from the circulation.
And
so very promising technology also, and also in a similar stage of development as a reversal agent for the 10A inhibitors.
And that is, in both cases, the antibody for dabigatran and the 10A sponge, if you will, for the anti-10As. Phase 3 trials in the U.S. have not yet started, but they're getting close. And so the hope is that it won't be too terribly long before we have these at our clinical disposal. One of the issues in studying the drugs, of course, is that these bleeding events aren't that common. As we've talked about, the need for reversal isn't nearly as common as the need for resuscitation and other treatment. Do you think, assuming these come to fruition, and we have vitamin K and 4-factor PCCs for warfarin, we have an anti-2A antibody for dabigatran, we have an anti-10A substrate for rivaroxaban and apixaban and edoxaban, will we then be at a point where we can say, at least from a reversal standpoint, these anticoagulant strategies are equally safe?
Well, I think the safety story will have to come out in clinical trials. But I think on a global perspective, as John pointed out, perception is not always reality. And the fact is that the NOACs, with their spontaneous recovery, their reversible nature, I think, and the ongoing data really suggests safety and efficacy and a lower risk of a lot of adverse events from bleeding. John, your thoughts?
So I think the availability of a specific rapidly acting reversal agent will give a lot of comfort to physicians, and it will provide in uncommon but very important situations a welcome strategy to rapidly reverse the new oral anticoagulant. So I think looking forward to the future, we can do so with great confidence, with even greater confidence when we have these reversal agents.
And there's a lot of active research in this area, as we've pointed out, that I think is really exciting and will give us new information and new therapeutic strategies.
So to sum up, we've discussed the fact that the need for actual reversal of an oral anticoagulant is rarer than one might think. These patients need to be treated first with resuscitation. We didn't consider factor repletion in a specific way or in a non-specific way. But the most important thing is resuscitate the patient and improve the substrate while we make the decision whether or not patients need to be reversed. Right now we have reversal strategies for warfarin which have been validated. In the U.S. we have a 4-factor PCC now, which the rest of the world has had for a longer period of time. So that makes us feel perhaps a little bit safer managing those patients. But again, the majority of patients who are bleeding on warfarin don't need to be reversed. They just need to be supported. One of the issues we have to deal with in these warfarin-treated patients is the longer half-life of this drug. Whereas with the novel oral anticoagulants, both the 2As and the 10As, there's a shorter half-life, so the patient needs to be supported through the period of anticoagulation for a shorter period of time. I think the group has agreed that in patients who have that life-threatening bleed on a novel oral anticoagulant, and we've sort of done everything else we can do for these patients, prothrombin complex concentrate is the way to go, hopefully in an effort to save those patients. But as you've heard, there are antidotes in development, both on the 2A side and the 10A side, which hopefully over the next 3 to 4 years we'll have reaching the market if the trials can be concluded quickly and, of course, successfully. So, gentlemen, thank you very much for joining us.
Thank you.
And thank you for watching.